Now, routinely, medical oncologists, cancer treating physicians are talking about how to integrate genomics and germline genetic testing, whether it's single gene, panel gene, Lynch syndrome, large panel, into patient care, into their workflow. Maybe you correct me here, but how many different recommendations for cancer types is genetic germline testing recommended for?
Almost 10 different papers have come out of this. One of them came out of JAM Oncology that was the high level, which reiterated what we have discussed before in breast cancer, but across all those cancer types, which is a universal approach is vastly more effective at identifying all those individuals who have underlying genetic risk for cancer. The evidence is becoming irrefutable. It is catalyzing a calling for universal testing, universal germline genetic testing for all patients with any cancer type for the purposes of getting those patients on the right therapies. With those kind of calls going out, there are a number of sites that are actively implementing that. All patients with cancer should ask their physicians for germline genetic testing. If their physician hesitates or dismisses it as unnecessary, keep asking. This can open opportunities for cutting-edge effective treatments that will not be accessible to you otherwise, whether FDA-approved therapies or in the context of clinical trials. And as we get better at treating cancer, this is also crucial to identify genetic cancer risks so that patients who successfully beat cancer do not go on to develop a new preventable cancer.
This is Genetics for Healthcare, a podcast for patients.
Thank you for joining us for another episode of Genetics for Healthcare, podcast dedicated to helping patients and their caregivers, their loved ones, advocate for a precision medicine approach to treatment, disease screening, and prevention. You can find us wherever you get your podcast, on Spotify, Apple Podcasts. And you can also find us on geneticsforhealthcare.com and subscribe. But also check out our social media platforms, YouTube, LinkedIn, Facebook, Instagram, and TikTok. While you're there, hit that subscribe button, especially on YouTube, to get alerts and updates for incredible new episodes like this one. Today, we have Dr. Ed Esplin, clinical geneticist and medical officer at LabCorp Genetics, to provide some history and background on the development and delivery of genetic testing products that today help us understand our inherited risk of developing diseases like cancer, Alzheimer's disease, and many other applications of genetic and genomic information that help us live longer and healthier lives. Dr. Esplin, thank you for being a guest on Genetics for Healthcare.
Rome, thank you very much for the opportunity. Glad to be here.
I love to get into the backstories of our guests, especially the experts in the field. I would like to ask you kind of what's your origin story for what attracted you for a career in medicine and why specifically clinical genetics?
Absolutely. So I'll give the path that I took, and then I'll tell you how I started on that path, if that's appropriate, which is, so I am a physician scientist. I am board certified in clinical genetics and internal medicine, and I have a PhD in genetics. I got there after serving a mission in Switzerland for the Church of Jesus Christ of Latter-day Saints. I completed my undergraduate work at the University of Utah. That was followed by medical school and PhD training at the University of Texas Southwestern Medical Center at Dallas as part of the NIH-funded medical scientist training program. I completed my internal medicine residency also at UT Southwestern and worked for a time as a hospitalist at the Dallas VA Medical Center. I subsequently completed my clinical genetics fellowship at Stanford University, and that was followed by a postdoctoral fellowship on familial adenomatous polyposis, also known as FAP, which is a hereditary colon cancer syndrome, with Mike Snyder in the Department of Genetics at Stanford. I practiced for a brief period of time as a clinical geneticist with Kaiser Permanente in San Francisco, and that was prior to joining Invitae as a clinical geneticist and medical officer. And recently, Invitae was acquired by LabCorp and is now considered the LabCorp Genetics division, and that's where I continue to lead clinical trials and genetics across clinical areas. Now, how did I get started on this path in the first place? Well, my dad, Dr. Glenn Esplin, he's a veterinarian, and he's got a PhD in pathology.
Okay.
He introduced me to the biological and medical sciences. Now, since he had the animal world covered, I decided to focus on people. Why genetics? I was born with congenital hypertrophic pyloric stenosis. This is a condition that affects the body's ability to process and digest food. And my parents learned what this was, and there's something wrong with me, because when I would eat, again, from day one of birth, I would eat just fine, but I couldn't pass it through my stomach. And after a short period of time, I would regurgitate, I'd vomit everything that I ate. And this persisted throughout my life at that point in time, which was not very long because I was getting very skinny very fast. They took me to the local pediatrician. I was born in St. George, Utah, so kind of a small town at the time. The physician there didn't know what was going on and recommended that they take me to Primary Children's Hospital in Salt Lake City, which was the largest medical center near to them, to be further evaluated, to better understand what was going on and what could be done, if anything, to address my inability to eat and obtain the nutrition that a growing baby usually needs. They took me up to Primary Children's Hospital there at the University of Utah. The physicians there did a fantastic job of diagnosing me with this condition, and I received surgery, corrective surgery, at 2 weeks of age.
Wow.
So, as the oldest of a family of 7 children, I witnessed my younger sister being born with the exact same condition. This time, my parents were able to tell the doctors themselves exactly what she had based upon the symptoms that she was presenting with, which is exactly the way that I had presented, and have it successfully corrected without delay. Later on, I realized that this condition in my family followed a Mendelian pattern of recessive inheritance, indicating there was likely a genetic component to that. This fascinated me, and I knew at that time that I wanted to learn more about the genetics of disease. And that is when I decided that my desire to enter medicine was going to include specializing in clinical genetics, as I have done.
That's a pretty incredible origin story to get into the field that since you were 2 weeks old, uh, I don't know when we started to get in leaps and bounds, but you did your clinical training in genetics at a very exciting time where lots of new innovations were emerging. The Human Genome Project was maturing. Next gen sequencing emerged over that period of time. I guess that was still a research technology, but it gave scientists the ability to read DNA and identify mistakes, mutations that may cause disease at mass scale, if you will. So when you were training, for whatever reason, we couldn't keep you in Dallas at UT Southwestern. But when you were training, like, what was the innovations like in clinical genetics in terms of the ability to sequence genes? I mean, was it NGS being used, or what technologies were happening in the ability of providers to get the information and then act on it?
A great question, and you already kind of touched on it. My career has been fortunate. I have been fortunate to get into this field at kind of 2 key turning points, as it were, in the field of genetics. So as I was doing my medical training and my PhD training at UT Southwestern, I was fortunate to do my PhD training in the laboratory of Dr. Glenn Evans, and he was part of the Human Genome Project at that time. So his lab was responsible to sequence a sizable portion of chromosome 11. And while I didn't have direct relationship with that, my PhD project was derived from a study of a subset of that chromosome 11. And so I was, to a certain extent, involved in seeing that Human Genome Project progress in the way that it did, and all that was, starting to be learned by that incredible project, which, as I'm sure you and many listeners understand, it took a long time and a lot of money to complete that. I think the overall Human Genome Project took 13 years to complete at the cost of over $2 billion. It was an enormous accomplishment, and it really paved the way for a lot of what we're experiencing now and what we have the opportunity to really bring to bear for patients in healthcare. I will say also that my clinical genetics training happened to coincide very serendipitously for me with the advent of what you referred to in terms of next generation sequencing. So the ability to sequence DNA at much higher scale and at exponentially more rapid rate than we were able to at the time of the Human Genome Project being completed. And in fact, we are now at a time when we are able to sequence one human genome at a cost of less than $1,000.
Wow. Yeah,
and it takes less than 24 hours to complete this process, which has opened that door and really made possible a number of the fantastic advances in terms of diagnostics and in terms of therapeutics for individuals with genetic related conditions to be able to access now. That really wasn't the case, again, before the start of this whole process with the Human Genome Project itself.
When you guys were training and working on that project, did you see like where we are today? Did you think it would take 5 years, or did you see all of the obstacles that would stand in the way, which includes regulation? Obviously, you have to develop the data to get reimbursement, but a big part of that was not knowing whether patients even wanted this information. What was the mindset when you guys were doing that sort of research with the Human Genome Project about making products that are commercially available?
Well, I'll be honest. I think a lot of what was going through our minds was really awe and astonishment with all that we were able to begin to understand better, and all of the crucial questions, the clinical questions and just the scientific questions that this data source was allowing us to be able to effectively pursue in a way that we never had been able to before. Take, for example, my thesis project was focused on a very small subset of chromosome 11. Basically, we were looking for a candidate tumor suppressor gene that's involved in lung cancer, colon cancer, some other cancers, and we found one that indeed met those criteria, and found this particular gene to be one that is seen in patients who have lung cancer, who have colon cancer, and it had potential therapeutic implications even at that stage. At least we could envision those, we could foresee those, that gene being a future target for therapies for patients with those particular types of cancer. And I think that's what a lot of the individuals involved with this, I can't speak for everybody, right, because I was only involved in a small group engaged in that effort, but there was a great deal of excitement for what we would be able to better understand about human genetic diseases as a result of this. And naturally, once you can better understand things, you can both give patients a more accurate, definitive diagnosis in a shorter period of time, reducing their diagnostic odyssey. At the same time, you have that opportunity to then develop better therapies. And I think that was definitely on everyone's minds, is how is this going to really change healthcare as a whole. What I think people didn't realize is how long it was going to take from the time that we finished that Human Genome Project, as it were, to its being more routinely utilized in medical care, which I feel like it is more routinely used now. There's still, as you've already alluded to, we're still just scratching the surface of the kind of impact that genetics can have on patients with various kinds of diseases, and importantly, right, their treatment. But I don't think we really understood how long it was going to take, and I'm sure that it hadn't crossed at least my mind, of course, as a graduate student at the time, the kinds of things like, will patients want to know this information? Is this information going to be something that insurers are going to actively cover and make available to folks as part of the standard of their clinical care? But these are clearly things that have bubbled up in the course of time.
Yeah. So you, I'm going to unpack something that you said. So like just the awe that you had in the possibilities of what this information could do. And you were on the front line when another key event happened in clinical genetics that almost like stopped the party before it got started. Because here on Genetics for Healthcare, a central premise that we hold is, innovation doesn't mean much if patients can't access it. And in the 90s, there was an innovative company that reportedly sequenced, I guess I can say that in air quotes. So at the time, they sequenced the BRCA1 and the BRCA2 genes, and they were awarded patents. And they started to market a product that was reported as the first test that provided evidence of the connection between a genetic variant and risk of developing breast and ovarian cancer. There's good and there's bad about this stuff. The good is the data demonstrated that if a woman has a BRCA1 or 2 mutation, or a male has a BRCA1 or 2 mutation, it increased risk. But specifically, the data on this particular product showed that it increased the risk of a woman developing breast cancer by 50 to 80%, certainly big news, and ovarian cancer by 20 to 50%. That's a good thing to know that you have that risk, and there's modifying lifestyle measures, preemptive procedures that you can do to prevent a cancer diagnosis. Now, the bad part of that was that company aggressively blocked other researchers in labs who were further researching the BRCA gene to create more innovations, because there was a lot more to learn that maybe was unknown at that time. And thankfully, on June the 13th, 2013, the Supreme Court issued an unanimous ruling that said, in part, that individual genes are beyond the domain of patent protection, can't patent a gene. And then secondly, in that ruling, it was said that genes are elements of nature, free to all men and reserved exclusively to none. Now, I got kind of a two-part question for you. Sorry for the preamble there, Dr. Esplin, but what was the potential downside of those patents being able to stand? And then secondly, what did the invalidation of those patents unlock or enable for scientists like yourself and providers, and ultimately, of course, patients?
You bet. Very important questions, and I'll also note I have some affinity for those individuals who had, of course, discovered the BRCA1 and BRCA2 genes, in part because that work was done at the University of Utah. And to your point, right, Myriad Genetics, based out of Salt Lake City, Utah, had then gone on to effectively commercialize this. And I'll give a certain amount of credit to Myriad Genetics, because I think it was based upon their ability to patent that they were able to develop a functional business model, which really laid a lot of groundwork for the utilization of genetics in clinical practice in a way that I think really hadn't been done prior to that. And so, yes, there is a great deal of credit that is due in that respect. At the same time, as you've alluded to, that did represent an obstacle, in my opinion, to innovation in that regard, because the testing that was being done, it was, and understandably, right, at the time that they started doing this testing, right, it was definitely like the leading edge of technology, right? It was the leading edge of medical science. It was really a complete game changer, just like you alluded to, for individuals who had breast cancer, and especially those who had a family history of breast cancer that followed the pattern that they had identified in hereditary breast and ovarian cancer syndrome, to be able to get tested, to understand that that is indeed what was causing their cancer. And that laid some of the groundwork for development of therapeutics later on. At the same time, it set a bar to access that was the cost of the testing itself. And it also made it very difficult, if not impossible, for other both researchers and commercial entities to research and develop advancing technologies that would do the job of genetic testing for BRCA1 and 2 or other genes and other conditions better, faster, and less expensively. And I speak of that in part too because I had joined Invitae right around that period of time, and one of the questions in the minds of those that were leading Invitae at the time was, is this going to be overturned, and will it persist in being overturned in terms of will this opportunity be opened to others to provide testing and eliminate the literal monopoly that that Myriad Genetics had. And so that presented an obstacle to innovation, to advancing both the technology and as well as to reducing the barriers of cost, for example, to patients to receive access to genetic testing and the genetic information that was critical there. And when that decision was made, it literally opened the floodgate for those who were ready, such as Invitae and others, to get in there and use the advances that technology had provided at that point in time and really to apply NGS technologies with the dramatic, literally exponential cost savings that those represented to clinical genetics, to get genetic testing that much more readily available to patients in the clinics, to physicians who are seeing these patients, and not just for BRCA1 and 2 at that point in time, right? There was already at that point in time a lot more that had been understood about hereditary colon cancer, such as Lynch syndrome, for hereditary epilepsies and other rare diseases, and everything was, to a certain extent, being held up by that patent, which, when it came down, those floodgates didn't just benefit folks with breast cancer. It benefited really everybody who had a familial condition or a known genetic condition that really would benefit from genetic testing.
So that is really rich what you just kind of articulated there, because it's one thing, and it's fair to say that they were able to commercialize and build the business and be the first to actually successfully commercialize something for patient access. But of all the other things that you mentioned, it's one thing to create a product, another thing to market it and create user demand. But it's also a quite another thing to generate the evidence that makes it relevant, actionable for healthcare providers to make treatment decisions or wellness decisions. And certainly the evidence is needed for payers, healthcare insurance companies, and employers who are going to pay for those tests. There's direct-to-consumer tests like 23andMe, or once upon a time 23andMe, and there's certainly others that will tell you things about your genetic predisposition or genetic markers that you have. That is marketed directly to consumer. You don't need a doctor to order that. And it will provide you information on your genetics. What's the difference between the way that you guys and your science team at Invitae set out to create and market those products versus a 23andMe that went directly to consumer?
So I'll start just by highlighting the difference between what 23andMe's genetic assessment was and what we were studying and what we were developing the evidence for in the form of clinical germline genetic testing. I'm going to refer to germline genetic testing. This is something that some folks are clear on and some folks are not, but that's the assessment so germline testing refers to testing a patient's DNA, oftentimes from a blood sample, and testing their DNA that they have inherited from their parents and could pass down to their children. So that's what I'm referring to in terms of genetic testing, just for clarification.
Thank you for the clarity.
Yeah, no, of course. And what 23andMe had done, is, as I understand it, their primary offering to consumers was a form of they called it a genetic array. And basically what it was is they designed a test that would look for individual letters in a person's DNA code, hundreds of thousands of letters in a patient's DNA code, and they would do their screen for folks using that level of analysis. It's a very superficial analysis relative to the 3 billion base pairs, 3 billion letters of DNA that each individual has. And it was never intended to be used for clinical purposes. And the distinction with what I have worked on, and I have done a lot of research in with Invitae and with LabCorp now, is clinical germline genetic testing, in which we utilize an assay that has been refined over years, again, derived from some of the technologies that were developed during the course of the Human Genome Project, but leveraging, more importantly, the next generation sequencing technologies that are really changing the space for the better, to do full gene sequencing of every gene that we choose to analyze, or that a physician asks to have their patients be analyzed for, so that we can definitively determine if a patient has a mutation in a gene that causes disease, or if, say, for example, for BRCA1, if a patient is free of any mutations in that particular gene, so that they can know that they are not at increased risk as a result of mutations in BRCA1. And I'll note that some of the greatest impact of genetic testing, of clinical genetic testing, as you've alluded to already, is in patients diagnosed with cancer, because germline genetic testing in these patients is important, both from the standpoint of identifying the cause for their cancer, but also there are a number of FDA-approved targeted therapies, such as PARP inhibitors, that are specifically indicated for people who have a specific positive genetic test result and are affected with breast cancer, ovarian cancer, pancreatic, prostate cancer, and others. Also important to keep in mind is that this is important for improving the healthcare of individuals with family members who have cancer, because without knowing that genetic cause, family members of a patient who have cancer may need to undergo preventive surveillance. But once that genetic cause is identified in the person who has cancer, then the family members can receive testing to determine whether they are at increased risk or not. And then those who carry the genetic risk can take advantage of, as you referred to previously, the preventive screening, sometimes risk-reducing interventions that mitigate that risk. And those that don't carry that increased genetic risk can avail themselves of standard screening protocols to mitigate their population level risk. And I'll also note that this isn't restricted to cancer, of course, right? Genetic testing has also dramatically accelerated the speed of diagnosis for patients with rare diseases. And we're seeing an ever-growing number of targeted therapies either becoming available, for example, for patients with epilepsy, or in development and active clinical trials taking place, where, again, for example, there are treatment regimens already in place for example, patients with epilepsy that require a confirmed genetic diagnosis in order to apply that therapy. One example is pyridoxine-dependent epilepsy, where patients have epilepsy and they don't respond to traditional antiepileptics, but they are effectively treated with high-dose vitamin B6, which you won't know unless you have done that genetic testing. And there's a study that's been done by McKnight et al. In JAMA Neurology, for example, that showed over 60% of the patients who had positive genetic test results received changes to their treatment that reduced or completely eliminated their seizures. And there are other examples as well. So how do we go and make the case for the clinical utility of this testing? One of the things that we encountered that my team and I had run up against is, historically, as was the case with, for example, BRCA1 and BRCA2, germline testing had been offered to a limited number of patients who presented with basically a textbook set of clinical features that defined a particular genetic syndrome, such as hereditary breast and ovarian cancer. Now, With the advent of next-generation sequencing, it was possible to perform germline testing on individuals who didn't exactly match that set of features, and we began to understand that the spectrum of those clinical features for many hereditary cancer syndromes and other rare disease syndromes as well was much, much broader than we had previously understood, and that the eligibility guidelines did not effectively identify all of those patients who would benefit from genetic testing. However, with genetic testing already being the standard of care for many patients with cancer and rare diseases, it wasn't feasible or ethical, for that matter, to perform a randomized clinical trial to establish the clinical utility of germline testing, where you would randomize people to, receive germline testing or to not receive germline testing in the setting of a known clinical diagnosis. And yet, the field needed evidence to support the clinical utility of germline testing beyond what the current guidelines recommended. So my team initiated a number of prospective clinical trials to address this important evidence gap.
Now, before we get into the evidence, because I got a lot to ask you about the evidence and kind of how you guys approach that, not just for cancer, for broader. You just mentioned epilepsy. There's a certain vision that it takes to go after those dedications from a business strategy. So I want to get into that in a second, but just to put a bow on the commercial direct to consumer, because there's a lot of patients who might be watching this who have said, or it's been suggested, you should get genetic testing, and they Googled it and they got a 23andMe. There's others who have maybe taken their 23andMe into the doctor, and the doctor says, I can't use that. It's not FDA approved or whatever. We can't make decisions on that. And their perception about the value of genetic testing was just kind of poo-pooed away. For those who may have, and there's millions of people who do have results from a 23andMe or a commercial direct to consumer versus, as you mentioned, a germline genetic testing done with NGS that is, volumes of evidence behind it, published peer-reviewed evidence. As a clinical geneticist, what do you say to those people about those who have a 23andMe and believe that they've got a similar product? What do you recommend or even suggest that they do there?
They need to get clinical genetic testing. And I'll do my best to paraphrase the FDA on this. They said as much as that, with respect to 23andMe specifically, that the results of those tests are not to be used for any clinical purposes, and that if anybody received a positive or a negative result from a 23andMe test or similar tests like you described, they should have both positive and negative results confirmed by clinical germline genetic testing performed by a CLIA-certified, ideally a CAP-accredited clinical genetic diagnostics laboratory before anything should be done with those results.
Thank you for that clarity. Okay, so you were about to get into what you and your team did to conceptualize the studies that expanded market access. And that's what Invitae as a company and a brand has been known for, as being one of the best companies in the space with getting patients access to germline genetic testing. And it takes strategy. It takes, time to gather the evidence, get payer coverage, get inserted in treatment guidelines, be endorsed by medical societies and associations like your team has. Can you talk about how you approach that? And, it could be any disease, because you guys have published, Dr. Esplin, you can Google him. He's published plenty of papers. But can you talk about the strategy and the vision on how you approach that and kind of what your intent was to ultimately benefit more patients?
Absolutely. So we were working within the context of the kinds of, at the very least, anecdotal and sometimes more substantial observations that there were more people with germline genetic mutations in various disease types and cancer types than people expected to see, and this broader spectrum of clinical features that would be representative of known syndromes like hereditary breast and ovarian cancer syndrome or Lynch syndrome. And so we came up with a hypothesis that if you test, for example, if you perform germline genetic testing on all the patients who have breast cancer, that you are going to find a lot more patients who have an underlying genetic risk for breast cancer than is currently being detected using the existing guidelines that restricted testing to people who met this clinical case description of you look like you probably have hereditary breast and ovarian cancer syndrome based upon your family history, based upon the type of cancer you have, the type of breast cancer you have, or the age at which you were diagnosed, or based upon your diagnosis of ovarian cancer. and part of that hypothesis also was we proposed that there was going to be very little difference in terms of the diagnostic rate of genetic test positive findings in patients who fell within the current, at that time, NCCN guidelines versus those that would not qualify for genetic testing under those guidelines. And so we set about to test that. And the first study that we did was focused in breast cancer. It was done in collaboration with a group that goes by the acronym TME. The lead author and lead investigator on this was Dr. Peter Beich, a great breast surgeon based out of Dallas area. And we enrolled 1,000 patients who had breast cancer, and our enrollment was open from the standpoint of the only real inclusion criteria was you had to have breast cancer. Didn't matter what age you were diagnosed, didn't matter how many family members you did or did not have that had breast cancer or ovarian cancer, didn't matter what your breast cancer looked like to the pathologist. If you had breast cancer, we were going to perform comprehensive 80 plus gene germline genetic testing, clinical genetic testing, and we were going to assess how many patients of all the patients who have breast cancer have an underlying genetic risk for that breast cancer. We did this over the course of a couple of years, and we found that close to 10% of all the patients who had breast cancer that were tested under this prospective observational clinical trial had an underlying genetic mutation, a pathogenic or likely pathogenic variant in one of their genes that contributed to their breast cancer, that indicated they had a genetic risk of cancer that was in some way contributing to their current condition. And we also found that when you stratified those based upon individuals who met that time National Comprehensive Cancer Network criteria, NCCN criteria for testing, and those who would not meet qualifications under those criteria, that the number of patients, the percentage of patients who had positive findings that met criteria was statistically no different from the number of patients who had positive findings and would not have been offered testing as a result of not falling into the current criteria, the current eligibility criteria that existed. So that proved one of our points, at least for breast cancer, that the guidelines themselves were underdiagnosing individuals who should be getting genetic testing because they have an underlying genetic risk of cancer.
So you literally took on the NCCN, those organizations who were setting the guidelines for who should be tested at that time.
Yes, we did. And we did it on behalf of patients because we were seeing that there were patients who would not get, who would literally be, in a way of saying things, refused the opportunity to receive genetic testing in spite of the fact they had a diagnosis of breast cancer simply because they were diagnosed at 46 years of age instead of being diagnosed at 45 years of age. And that didn't seem right to us, and we wanted to generate some evidence to test whether or not we were right in believing that that's not right. And we followed that on with the same group of patients. It ended up being just over 900 patients, and we followed to see what difference, what clinical utility those germline genetic test results had in those patients who had gotten testing, many of whom would not have gotten testing as part of the standard of care for, based on the current guidelines at that time. And at a high level, we found, based upon, again, the physicians who were treating these patients, many of them breast surgeons, some of them medical oncologists, that for 2/3 of the patients who had positive germline genetic test findings, this being breast cancer patients, for 2/3 of them, the physician said that genetic test finding has positively impacted that patient's clinical health outcome. Furthermore, for 1/3 of those patients who had breast cancer who had a negative genetic test result, the physicians also indicated that for that 1/3 of patients, their negative genetic test result also positively impacted their overall health outcome, which was honestly unexpected to me. But that underscored, one, the actionability of the positive results, that those positive results were being utilized to guide surgical approaches, that were being used to help individuals get access to PARP inhibitor therapy, right? One of the precision medicine, the precision oncology treatments that is FDA approved in patients with breast cancer, ovarian cancer, prostate, pancreatic cancer, when they have a germline genetic mutation in BRCA1, BRCA2, and sometimes other genes. Furthermore, for those patients who tested negative, they had the opportunity to consider whether they could have a de-intensification of their surgical approach. They may not need to have a bilateral mastectomy as a risk-reducing intervention. They could have breast-conserving therapy instead, which has all kinds of benefits in terms of shorter times in the hospital, right? You're less aggressive surgery, preservation of the breasts themselves to the degree that's possible after the surgical approach. So this made a huge difference in terms of illuminating evidence about the clinical usefulness of genetic testing that was so impactful that at the time, this is back in 2019, the American Society of Breast Surgeons took that evidence and they, in a matter of months, they changed their recommendations and they issued brand new guidelines indicating that they, as a society, recommend germline genetic testing for all patients who have been diagnosed with breast cancer or who have ever been diagnosed or treated with breast cancer as part of the standard of care for those patients.
So folks, this is why I asked Dr. Esplin to come on to kind of give the background of what it took to even get a test to the market. And then you have to address the challenges once that test has adequate data that shows that patients should get it, that all patients don't get access to it because of the barriers that are set up for medical practice or the indications, or even in some cases that has a large effect on patient access, insurers, payers that are going to pay for it, even when there's evidence that exists that it's going to be beneficial for patients. And Dr. Esplin, really, your team went on to continue that approach of challenging the expansion of guidelines, challenging what they've put in writing to say, is this really the right thing to do? What about these patients over here who could benefit from this information? Today, the industry seems, and we're switching to oncology specifically, the industry seems to have reached a tipping point, at least in the last 5-6 years since that first paper in breast cancer that expanded and challenged the guidelines. Now, routinely, medical oncologists, cancer treating physicians are talking about how to integrate genomics and germline genetic testing, whether it's single gene, panel gene, Lynch syndrome, large panel, into patient care, into their workflow. Maybe you correct me here, but how many different recommendations for cancer types is genetic germline testing recommended for?
So I know this only because I read these guidelines maybe like every other day, which is not normal, but that's part of what is required in this field at this time. And I'll lead into this by noting, as you already alluded to, after we had done this study in breast cancer, we did a number of other studies. One of them was the INTERCEPT trial. This one happened to be led by Dr. Jules Matter, based out of the Mayo Clinic, and this one, similar to the previous, it was investigating universal germline genetic testing for all patients with cancer, and it accrued patients from the Mayo Clinic sites, from the 3 different Mayo Clinic sites, Arizona, Florida, and in Rochester, and it enrolled about 3,000 patients. Across those 3,000 patients were represented patients with 14 different cancer types. All of them received germline genetic testing. Uh, all of them were followed longitudinally to see, one, what was the result of that test, and in the context of, what their clinical criteria were, and would they or would they not meet the guidelines that currently existed for those folks, as well as what was done for those patients as a result of those genetic results being available to their physicians and the patients themselves to change their treatment, and to what extent did that impact their outcomes. And to make a long story maybe a little bit not quite so long, almost 10 different papers have come out of this. One of them came out of Gem Oncology that was the high level, which reiterated what we have discussed before in breast cancer, but across all those cancer types, which is a universal approach is vastly more effective at identifying all of those individuals who have underlying genetic risk for cancer and who have genetic findings that can and should impact and guide how they're being treated and how they're being monitored after being treated. And in particular, one brief highlight to make on that is the work done in, for example, colorectal cancer was useful. In fact, was key in a future NCCN discussion where we had found that I think it was upwards of at least 1 in 10 individuals who had colon cancer and were tested using germline testing were found to have a pathogenic mutation that was in a cancer gene that conferred risk or conferred ability for particular treatment interventions. And to the credit of the investigators involved, they presented that information to the NCCN, and the NCCN did go on to expand their recommendations for testing in patients with colorectal cancer, essentially endorsing a universal testing approach for patients with a diagnosis of colorectal cancer, where they said explicitly that everyone who is diagnosed with colorectal cancer under the age of 50 should receive germline testing, and germline testing should at the least be considered for every single patient with colorectal cancer who is diagnosed greater than 50 years of age. And that has been actually recapitulated to a certain extent for patients with uterine cancer, where again, everyone with uterine cancer really is recommended to have testing, or should at the very least be considered to have germline testing. And this goes along with also existing guidelines that support universal testing for patients with pancreatic cancer, patients with ovarian cancer. And so to your point, this is the evidence is becoming irrefutable, and it is catalyzing a call. For example, from doctors Vivek Sabia and Roselle Kurtzrock, they wrote an article pretty recently calling for universal testing, universal germline genetic testing for all patients with any cancer type, for the purposes of getting those patients on the right therapies. And with those kind of calls going out, there are a number of sites that are actively implementing that. So Dr. Smatter out at Mayo Clinic, after the remarkable success of their trial, they have started implementing as the standard of care, not in a clinical trial setting, but as the standard of care, universal testing for every patient who presents to the Mayo Clinic with the diagnosis of cancer. they are getting germline genetic testing. This is also being done at the City of Hope. This is being done at the USC Keck Cancer Center. There are others out there that are implementing this and are seeing the benefits to patients of getting this information at the beginning of their diagnosis, so that can inform the entirety of their cancer care and ideally, change their outcomes overall.
So everything you're saying is extremely important, and you call the names of these leading academic centers because they're training the next generation of cancer treating physicians that are going to go out and implement, those practices, and when they become private practitioners or join a group. Even recently, we talk about colon cancer and genetic insights to help treat disease. Most recently, the NCCN updated their guidelines to include DPYD pharmacogenomic testing for colon, rectal, anal, small bowel cancer. But I think we're back at square one again. Does the recommendation go far enough? Because they don't say these patients should be tested. It says in a recommendation to clinicians, you should have the discussion. And if the patients want the testing, then you can order the testing. But hey, test. My father's a colon cancer survivor. If we'd known that information, test, right? So maybe it doesn't go far enough. I'm not asking you to comment on that necessarily. But here's what I will ask. We're talking about the industry reaching the tipping point, and despite all of this new guidelines and the academic centers, the excellent facilities that you mentioned that are implementing these genetic and genomic insights into their workflow, so patients can have this up front because it can guide clinical decisions downstream. 80% of patients are treated in the community setting, right? Where they're not necessarily specialists that see colon cancer all day, every day. They see, a myriad of cancer types that will walk through the door. And there was a paper published a couple years ago in JAMA, the Journal of American Medical Association. And it reported that in California and Georgia, between 2013 and 2019, it found that germline genetic testing was still low. Among more than 1.3 million patients in the review in this study, only about 93 patients, or about 6.8%, underwent germline genetic testing, according to the published findings. Men diagnosed with breast cancer had the highest rate of testing, and it was only 50%, Dr. Esplin. 38% of ovarian cancer patients were tested, got testing. Recommendations, the guideline recommendations is that all people with these two cancers receive germline testing, genetic testing. Among women with breast cancer, it was only 26%. BRCA1 hereditary cancer was launched in 1996. And this report published in 2023, only 26% of these patients in the study. Maybe it's unfair to ask, but if we did this study currently, would the numbers look any different? I guess my point is, how long does it take for patients to be able to access these innovations that come to the market?
Yeah, it's you've highlighted a source of frustration, to say the least, for me and many like me, and I think you call out a key piece there where you're noting there are those individuals, right, and currently, right, everyone with breast cancer is recommended for testing. Everyone with ovarian, pancreatic, obviously the male breast cancer you mentioned before, everyone with colorectal and uterine cancer really should be at the very least considered for germline testing and receiving this. And we're seeing, even for those where the guidelines have existed for a long period of time, the implementation has been 50% at best, which is a dramatic underutilization, and it's a huge missed opportunity for patients. And I wish I had an answer for like, when is this going to get fixed? Clearly, myself and members of my team and others similarly situated are working hard to address this, because we're trying to understand, like, what are the obstacles. Now, to be totally fair, right, that study, as you appropriately noted, started looking at patients who were back in 2013 up to the 2020s, and so the guidelines in 2013 clearly were not as advanced as they are today, and Dr. Curry et al. Did note that there was an upward slope to the uptake of testing across that time period. So there was gradual improvement across many of those cancer types. They did also note that there was improvement, but there was somewhat slower improvement and somewhat less uptake, unfortunately, among patients from historically underrepresented and understudied populations, which is also a challenge, needless to say, in terms of access to, again, all of these advances in medicine. So what I have found is one of the outputs, the beneficial outputs of a lot of the research that we have been doing and we continue to do. In fact, for example, right, we're in the middle of a study right now that is focused on the implementation of universal germline genetic testing in patients with any kind of cancer, any kind of solid tumor cancer, in a community setting. It's awesome. Being done in collaboration with Dr. Kashyap Patel. He's out in South Carolina, and the catchment area of his patient population is, if I recall correctly, it's around 60%, Northern European, about 20 or 30% self-reported African American, Hispanic and Asian in there as well. But it's in this community setting where we are working to demonstrate that it's not only feasible, but it's making, again, a difference in how these patients are being treated.
That's huge.
And how the utilization of genetic information in the form of germline genetic testing changes and improves their outcomes. I'll also give a shout out to Dr. Shelton, Outer Banks Hospital, again, a community hospital out on the East Coast. And as soon as the American Society for Breast Surgeons came out with their newest guidelines, again, back in 2019, 2020, recommending universal germline genetic testing for all patients with breast cancer, he set about to implement that at his hospital, at his community hospital. And he has done that very effectively. And in fact, we were able to collaborate with him on just looking at some of the data that he's generated over the course of over 200 patients with breast cancer that he has seen. And he effectively implemented that. He's had the support of a genetics trained nurse practitioner out there, and they have done a remarkable job of getting well over 90% of the patients who have breast cancer genetic testing, right? There are some folks who choose not to do it, but the vast majority want that information, want that to be in the hands of their treating physicians. That has made a difference in how they are choosing their surgical approach. There was I think 20% of those individuals who tested negative, who changed their minds and chose to pursue a breast conserving surgical approach as opposed to a bilateral mastectomy as a risk-reducing intervention, when they found that they did not have the increased risk that BRCA1 or BRCA2 confer. And I think, to your point, the community clinics and the physicians and other clinicians taking care of patients in these clinics, they have a lot of responsibility. They have a lot of things that they're needing to deal with. And one of the biggest challenges that we face is helping to increase awareness among these physicians and other clinicians that are the boots on the ground, that are taking care of patients on Main Street, that are taking care of the vast majority of cancer patients and other patients with rare disease, helping make it easier for them to know what the current recommendations are, and equally importantly, making it easier for them to implement germline testing for all the patients who qualify, without placing an additional burden on them in their busy practices, which is what many are concerned that this represents, is one more thing they need to do, and they've already got a list of a lot of things that they feel challenged to be able to meet in terms of providing the best care to their patients, which is of course their intent. And I'll tag that on to say there is also opportunity for increasing awareness and education, not only among treating physicians but among patients.
Okay.
Patients are, as you well know, and I think as your effort here clearly embodies, the best advocates for themselves and their health. And as a treating physician, not an oncologist, but as an internist and as a clinical geneticist, I appreciate having patients bring to me things that they have read about, questions that they have, asking me if a particular test or if a particular approach is something that's appropriate to them, because I'll do my best to keep up with everything in the literature, but patients become experts with their own condition very quickly, I think, out of necessity, unfortunately. And it's an opportunity for both us as the genetic community to raise the awareness of and educate patients about the importance of germline genetic testing for patients with cancer across the board, for patients with rare diseases like epilepsy, like cardiomyopathy, like high cholesterol, autism, developmental delay and disability, and help them to prompt their physicians, to ask their physicians about genetic testing, especially in those cases where there are clear guidelines and clear evidence that support this. And the last thing I'll note about this is, you've already touched on it, right? Clearly, we need insurance policies to be updated to incorporate all of this evidence that has been accruing, the recommendations that changing on a regular basis and being updated on a regular basis in support of genetic testing. And I will call out what unfortunately is an unusual example, but kudos to this particular example. And this is an example of a very up-to-date and evidence-based medical policy for germline genetic testing in patients with colorectal cancer. This is the policy of United Healthcare. I think it's the largest commercial insurer in the United States. They put this policy into place back in 2020. And their policy supports, as medically necessary, germline genetic testing for every person who is diagnosed with colorectal cancer. And it doesn't stop there. It's medically necessary under their policy, and their policy supports testing of every individual who is diagnosed with any cancer that is associated with Lynch syndrome, which includes uterine cancer, which includes thyroid cancer, which includes small bowel, long list of cancer types. They put that policy into place, and that's the kind of thing that we need to see happening across other insurers. And also, we need physicians and patients to know, for example, if you're covered by United Healthcare, make sure you're getting testing if you have colon cancer or if you have uterine cancer, because it's a covered benefit. We did a study a little bit ago, just looking retrospectively at patients who were covered by United Healthcare. And we found that in spite of the fact that that universal coverage policy is in place, less than 10% of all the patients covered by United Healthcare who had a diagnosis of colorectal cancer received germline genetic testing. And it was a covered benefit for them for which they qualified. And that's where we have an opportunity to, again, educate clinicians, educate patients to avail themselves of what is clinically recommended based upon the guidelines and the medical evidence, and what is supported by an insurance policy as well.
Gosh, that's so good. Dr. Esplin, I really, really appreciate you being generous with your time and giving this information to our listeners and those who are watching this, because this is extremely valuable. For those of you who might be listening via different social media platforms, you can go to geneticsforhealthcare.com and subscribe so you can get these new episodes delivered to your inbox. We're going to make sure we clip what you just said about that medical policy, because it really is about patient access. We've been discussing the challenges that came since you were in training to conceptualize what can be done, and the doing part you've been committed to with an incredible team of scientists and professionals to get these products to the market and with evidence proof of clinical utility and where payers will pay for it. And they are, and we still see through different surveys, studies, and real world examples that we've had here, even on, Genetics for Healthcare, this podcast, that patients aren't getting them. So I love to end by asking our guests for 3 practical tips. Now, this is not a medical advice show, but I appreciate having Dr. Esplin on, who can read from medical policy because that's his job, to read and to inform medical policy. But Dr. Esplin, for those who are out there who may be thinking about germline genetic testing, whether it is for cancer diagnosis, or they battle epilepsy, or any number of diseases, what tips can you give them to help support them and advocate for themselves, to give them the language and possibly the confidence to advocate for themselves, to go talk about this and request this from their medical providers?
Absolutely. Now, I could talk about this for a long time, but I will keep it as concise as I can. And some of this will sound similar to what I've noted before, but I'll condense it here. So, all patients with cancer should ask their physicians for germline genetic testing. If their physician hesitates or dismisses it as unnecessary, keep asking.
Mm-hmm.
This can open opportunities for cutting-edge effective treatments that will not be accessible to you otherwise, whether FDA-approved therapies or in the context of clinical trials. And as we get better at treating cancer, this is also crucial to identify genetic cancer risks so that patients who successfully beat cancer do not go on to develop a new preventable cancer. We did a study just a couple of years ago, and we found that almost 10% of the patients that we had seen for testing, for germline testing, had only received that germline testing after they had developed a second cancer. And if the testing had occurred at the diagnosis of their first cancer, many of them could have known to engage preventive screenings or preventive interventions to at the least mitigate their risk of the future cancer or completely eliminate the risk of that future cancer ever taking place. That's number 1. Number 2, all patients with epilepsy, cardiomyopathy, high cholesterol, autism, or developmental delay disability should ask their physicians for germline testing. And keep asking. The evidence is there. The guidelines support it. And this also can open opportunities for effective treatments and will also help accelerate the development of new therapies for patients with diseases that are individually rare, but they are common in aggregate. And 3, for those who are looking for reliable information about cancer syndromes, about other rare diseases and other syndromes, I highly recommend genereviews.org. It's a reliable source. It's better than just Googling your condition. And it's a source that is peer-reviewed. It is updated on a regular basis by genetics professionals and other clinical professionals that are specialists in their field. And it can provide a great deal of information about both the genetics of these conditions, about how they are diagnosed, about prognosis information, and importantly, about treatment and potential clinical trial information as well. That's genereviews.org. Again, obviously, it's a nonprofit, but I reference it frequently, and as a practicing clinical geneticist, I routinely recommend it to and point my patients to it as well, because it has information that I will also say is not just, it's good for clinicians. I mean, it's definitely good for clinicians too, but it's also, I believe, written in a way that is as accessible as any medical literature can be for patients and other folks who don't read this stuff all the time.
incredible resources. And we'll have these links to genereviews.org and also some of the studies that he has mentioned on our episode page at geneticsforhealthcare.com. Dr. Ed Esplin, thank you for sharing your story, your personal story with us. I just think that was an incredible origin story to be working on the problems that you are today. Thank you for the Herculean efforts and leadership to the scientists that have forged the market and expanded patient access so more patients can have this information to better their health and prevent disease. And thank you so much for being a guest on Genetics for Healthcare.
Thank you, Rome. It's been an absolute pleasure. I greatly appreciate it.